Hi everyone, and thanks for taking the time to meet with me today to outline my project to reduce the incidence of pressure injuries acquired in the perioperative timeframe. This project relates to National Safety and Quality Health Service Standard number 8, preventing and managing pressure injuries, in this case in the operating room. Recently, I flagged a clinical indicator regarding the level of pressure injury acquired within the perioperative timeframe compared with that of the rest of the hospital. In fact, it was over double, and rather than decreasing, which is what's happening in the rest of the hospital, it's actually increasing, currently 9% compared to 4% in the remainder of the hospital. The economic toll of this is difficult to quantify, however it is estimated to be close to $1.6 billion for all pressure-related injuries in Australia. But to get a clearer picture, it costs 2.5 times more to prevent a pressure injury than to treat one, causes significant pain and disfigurement, and extends hospital stays from an average of 4.8 days to 11.2 days. This presents an opportunity for us as leaders in healthcare delivery within one of Victoria's largest healthcare providers to recognise the causes of this and propose strategies to improve patient outcomes and to benchmark a new hospital standard that can be utilised across organisations using skills and resources that we already have to hand. To start with, it's not all bad news. I'm here to tell you that what we are currently doing to prevent pressure injuries in the operating room is mostly right. We utilise all of the resources available to us to physically safeguard the patient from acquiring a pressure injury during surgery. We have state-of-the-art theatres, technically advanced equipment, standardised training, and these all limit the extrinsic factors behind pressure injury creation. We use this equipment routinely and safely and to good effect, and we pride ourselves, and rightly so, on how well we use this. However, pressure injuries required in the operating room continue to remain a concern. So, a pressure injury generally does not show up to about 72 hours post-operatively. There is a disconnect somewhere. There are flags that we are missing. Despite best practice, the prevalence of pressure injury in the operating room is something we need to consider. The predominance of pressure injuries acquired in the operating room essentially relates to the overall perception about the length of surgery and nurses' knowledge of the perioperative period. The risk of acquiring a pressure injury increases up to 78% the longer the procedure lasts, and many nurses in the OR are unfamiliar with pressure ulcer prevention or formation, often leaving this to the focus of theatre technicians or the surgical team. Many consider pressure injury prevention to be the domain of the ward pre and post-op and outside of their scope of practice. Factors render patients who would not normally be at risk of acquiring a pressure injury suddenly jumping to the top of the risk queue. Nurses furthermore may consider that a 2-hour surgery will not cause a pressure injury, however they do not take into account the other variables. When you consider the diagram, a 2-hour procedure actually lasts a lot longer and hence the increased risk of the development of a PI that we won't see in theatre but we will see on the ward in about 72 hours, and it's this time frame that I'll be looking at, the one that extends beyond the theatre doors to the time before theatre admission and extends after discharge to the ward, a space in which there is currently no existing standard for pressure injury prevention. So the goal of this project is to reduce the incidence of pressure injuries acquired in the operating room by 30% within 18 months. The project aims to do this by the creation of a hospital standard around the perioperative timeframe, by developing an interprofessional pressure injury prevention team for patients undergoing surgical interventions. There are 3 proposed strategies that are all intertwined. The creation of an interprofessional team to work across the spectrum of the perioperative timeframe, who will be responsible for delivering on the other 2 objectives or proposals: an audit of existing documentation and the creation of a perioperative pressure injury prevention standard. So objective number 1 is the interprofessional team that will be responsible for the audit and the creation of the standard, with establishment of the existing level of knowledge and a baseline for future training and education. The interprofessional team would interact interdependently with a common purpose, working toward measurable goals that benefit from leadership, maintaining stability whilst encouraging honest discussion and problem solving. It will comprise staff from a cross-section of the perioperative timeframe who have a solid understanding of the risk factors associated with pressure injury formation and prevention and capable of assessing and accessing key data. The team would be decided within 1 month of the agreement to commence the project and have a deliverable timeframe. Further strategy would be to meet every second week at a predetermined time, have terms of reference, establish a timeline for the project and anticipated costs, maintain accurate recording and reporting, and establish project evaluation and allow sufficient time for this in the planning phase. The team will create and conduct evaluation surveys assessing the working knowledge of the definition of the term perioperative and their understandings of the preventative strategies for pressure injuries to provide an evaluation benchmark. During this process, the interprofessional team will conduct an audit of existing documentation, capturing such things as timeframes to identify at-risk clients who would not normally present as such, actual incidents of operating room acquired pressure injuries, and when a pressure injury prevention could have taken place. They will consider, for example, extended periods of time spent supine, such as during admission, pre-op waiting times, extended recovery times, and post-operatively. And finally, the third objective is the creation of a perioperative pressure injury prevention standard that works across the interprofessional spectrum, informed by the findings of the audit and surveys of the existing knowledge base of the staff involved in perioperative practice. Sufficient time needs to be provided to ensure a thorough evaluation is conducted and is collected in a comprehensive manner. This is reliant on evaluation commencing from the inception of the project and be clearly articulated in the planning with a pilot survey of staff informing appropriate design and consistency. The surveys can take the form of interviews and online to glean multiple levels of knowledge across a spectrum of staff. This will be done at regular intervals to assess the degree of efficacy of the education and training, especially before and after, to identify changes and enable the team to act upon this information to alter their plans as required. The evaluation would inform the creation of the standard. Operating room acquired pressure injuries are an overlooked area of cost, both human and material. We currently possess the knowledge and resources to address this within the perioperative space, and the creation of a hospital standard that considers this has the potential to save on both in a timely and cost-effective manner. Thank you for listening.